I'm Carey Jackson, and my task in the next 10 to 15 minutes is to talk to you a little bit about the attitudes of the primary care docs that we're hoping will step up and partner with us around TB control. Now, the fact is I'm not a TB controller. I'm a general internist, a primary care doctor myself. I work in a setting with a number of my colleagues at a teaching hospital in Seattle, and in the clinic I work in, we see only foreign-born patients. And as an academic, I've also worked in a number of prevention trials, and so for that reason I was recruited by colleagues in the local TB control effort, notably Charlie Nolan back when he was the TB controller, and Masa Narita now, and my colleague Jenny Pang, who played an instrumental role in the work I'm going to talk to you about, as well as colleagues at CDC, Wanda Walton, and Nick DeLuca, and a host of talented people across the country who are noted here, who had a role in the work I'm going to talk to you about. And specifically what I'm going to say to you is things you already know, which is basically what you know doesn't explain how you feel, and what you know doesn't explain what you do necessarily. There are other things that explain it, and that's the long and short of what I'm going to tell you from this study. But having done the study, I'm going to give you the details. The main objective of the study was to follow up on the suggestion of the National Coalition for the Elimination of TB when they said to the Congress that they felt that it was a priority to prevent, detect, and treat TB and latent TB among foreign-born persons, and that for that reason those physicians serving impoverished individuals and new arrivals to the U.S., such as the physicians in FQHCs, community clinics, and migrant health centers, and in public hospitals like mine, and foreign-trained physicians needed to be supported as they were to take on this task. Now, about a year later, an investigator named Kimberly Yarnell in the American Journal of Public Health published a paper that said, primary care, is there enough time for prevention? And what they did in this study is they took all the U.S. Preventive Task Force recommendations and modeled how much time it would take for a primary care physician to implement all those recommended tests. And they did conservative modeling. It turns out that it'd take 1,773 hours of a primary care doc's time, or 7.4 hours every working day, to just do prevention, not to mention manage chronic disease or to manage any kind of acute injury like I slipped on the ice and my bottom hurts. And so as a result, it's ludicrous, and docs are in a position of having to choose which of these prevention guidelines they implement. Add to this the complexity of discussing latent TB with a foreign-born patient in your setting and convincing them to be tested and to take INH, and you get what primary care physicians are up against. But nevertheless, it's important to do, and primary care physicians agree that prevention is important. So to this end, we engaged in a study to look at what knowledge, attitudes, and beliefs were of the primary care docs who were taking care of foreign-born patients across the country, and to look for practice features that facilitated or obstructed the management of latent TB, and to see if an educational intervention would have any impact. These are the study sites from Boston to Honolulu, including 2 places in Seattle in a private setting as well as a public hospital, San Francisco, Orange County, California, and Dallas-Fort Worth. And we targeted those clinicians that were serving the highest risk populations in the States, Mexicans, Filipinos, Vietnamese, and Chinese. These are the largest communities. You met criteria to enter the study if you were a primary care provider in family practice, internal medicine, pediatrics, or women's health care. If more than a quarter of your panel was foreign-born, if you'd been in practice at least 3 years and a year in the current side of practice and you had no contact with public health, that is, you weren't a public health employee also somehow. Now, the first phase of our study was qualitative. We interviewed individuals and groups of people in these settings across the country just to see what the general knowledge was and attitudes. And I'm going to focus in on not the knowledge here, but on the attitudes towards care, because that's why I've been asked to speak. And these docs generally said things like, TB clinic rarely communicates with us, I don't have a way to track PPDs or quantiferon, if patients are compliant taking their therapy. Patients won't take INH for 9 months. Or the guidelines are confusing and constantly changing. They also said, I have too many patients and too little time to address this, I'll lose money. Now, if you look at the kind of quotes that produced these themes, were things like this quote from a San Francisco physician. Well, the TB skin test I didn't routinely do on Medicare age people unless they're going to a nursing home. because there's no reimbursement for homemade care for TB placement, he meant PPD placement, unless they have specific symptoms. If they have weight loss and stuff like that, then we check it. But we cannot do it for just routine physical, whereas other insurance, well, we can do it as a routine physical. They reimburse. Medicare doesn't reimburse. Medi-Cal, I don't think they reimburse. That's even worse than Medicare. So we took these attitudes, a number of these attitudes, and tried to develop survey items, and we came up with 56 items to address attitudes that were basically asking similar questions in different ways to get at these themes. We combined these with some 48 questions on the epidemiology and the CDC ATS guidelines around testing and treating and risk populations, and then some demographic questions, and invited 10 to 14 primary care providers from these sites across the country to sit and take this survey and then have dinner and listen to a 1-hour didactic intervention by the local TB controller as they went over these items and taught them what the guidelines were, what the risk populations were, what the local epidemiology looked like in the foreign-born communities, what local policy was, what was available in terms of practical tools, and how to test and treat, focusing primarily on latent TB. And then after that evening, within a month, after 2 weeks, the same survey was sent out without the demographic items to see what impact the intervention had made. And again, this is largely an educational intervention. So this is who we ended up talking to. It was a small sample of 80 people. On average, they were 48 years of age. 40% of them were female. Some of them were from the U.S., and a large number had immigrated, so they were foreign-born physicians themselves. And when they immigrated, on average, they were young adults. Those that didn't come from the U.S. came from the Philippines, China, Vietnam, Taiwan, and other places. Most of them were DOs or MDs, 77%. There were some mid-levels that made up 14% of the sample, and a couple of pharmacists and specialists. But they had been in their current practice position on average a fairly long time, 17 years. So these were seasoned physicians. Now, about half of them were in solo or group practice, what I'm going to refer to as fee-for-service or private practice, and the remainder were in a public setting, a community clinic, an FQHC clinic, or public hospital. They were internists, 40% of them, pediatricians, about 15% of them, family medicine, 37%, and a couple, as I mentioned, were either specialists that did a lot of primary care or pharmacists. About half of them had formal TB training, either in medical school, residency, from the CDC directly, or some other website. And half of these, 46% of these that had TB training, had multiple contacts with training. On average, they saw about 20 patients a day. They spent 70% of their time in patient care. They estimated that about 60% of their panels were foreign-born. For this reason, they placed about 20 skin tests a month, and of these, they thought about 30%, 28% or so were positive. So in summary, these are the docs that we want to share the task with. These are the docs that are busy, they're active in the foreign-born community, they're placing skin tests already and reading them, and these are the people from whom we solicited these attitudes. Now here are the results, and I want you to just, I've sort of combined the agree and strongly agree columns here. And we took those 56 items and got rid of the redundancies and identified the items that seemed to work the best to identify attitudes, and eliminated other attitude items that were really about local TB practice that wasn't generalizable across the country. And we came up with these 16 items. And I'm going to just kind of give you what the general impressions were as you go down the agree and strongly agree columns here on these items from these doctors. Patients don't want to take time for prevention. About 38% agreed or strongly agreed with this point. Patients don't want to pay for prevention. 58% of the sample felt this was true, or agreed or strongly agreed. Patients' insurance type affects the provider's ability. About half of them, or 54%, said this is true. Now, providers worried about the effect of INH on the liver, only about 29% of them felt that this was true, or agreed or strongly agreed with this opinion. There were pressure on providers to maintain high productivity. Fewer people than I thought endorsed this. 36% said that this was the reason that they agreed or strongly agreed with. 76%, however, felt that LTBI management was the responsibility of the primary care physician. 68% also felt that, of the same sample, felt that this should be taken care of by the government. So I'm not sure if this is contradiction or they feel it's a shared practice. 64% felt that communication from the TB clinic to the practice about patients' needs needed improvement. And 34% felt that the recent erosion in TB clinic service signaled TB management was no longer a priority. Most of them realized that it was still a priority. The overwhelming majority, 91%, felt that the public health system needed to increase awareness of TB among immigrants from the countries with endemic TB, that would help their practice. So when we looked for those things that were helpful or very helpful in managing latent TB in practice, these were the things that were endorsed. 86% felt that free PPD solution would help. 90% felt that free INH would help. Only 47% felt that a contact person would be helpful, but 98% felt that a formal tracking system that included LTBI management would be helpful for them if it was designed. But if you asked them if it was a significant reason for not treating, only 33% felt that it was a significant or moderate reason for not actually screening, testing, and treating for latent TB. And then if you looked at the role of BCG, because many people have mentioned this, only 14% felt that it really muddied the water and obscured the diagnosis. These same questions we looked at to see if there were any of the demographic features that associated with these same items. In other words, could age or duration in therapy, whether or not you got TB training, if you were an immigrant doctor versus a U.S. doctor, if you were trained in medicine or pediatrics, did any of these things, gender, if you were a female doctor or male doctor, did any of these things associate with these attitudes? And the thing and nothing emerged as significant except for whether or not you worked in private practice or in a public setting. That is, if you were in fee-for-service or salaried. And these are the items that became significant here, as you can see. Providers worried about INH's effect on the liver about more than twice as much if they were fee-for-service. That TB and LTBI should be taken care of by the government was felt twice as 2.48 was the odds ratio for that attitude. That free PPD solution would be helpful in practice. The odds ratio there was 6 for private over a public setting and 4 for free INH for patients. And twice as often, contact person at the TB clinic to manage LTBI was felt to more strongly in private than public setting. And finally, the BCG issue did come up, was more strongly associated with this attitude in a private setting than in a public setting. So, in summary, really quickly, in this study, we saw significant improvement in knowledge by the intervention. We haven't looked at that here. But the attitudes did not change whatsoever after the educational intervention. And some of that is explained in this slide, because these attitudes are sort of a result of context more than they are of information. This physician in Dallas said, TB is very rare, so LTBI screening is not critical. But it's pretty much, in my opinion, a waste of money, because I might find 1 out of 200. I'd have to screen 200 people before I could find one case. And most patients would not, they'd have to do it as a freebie because they're not going to pay for that. It costs me about $5 a test. Another physician in San Francisco said, I have too many patients and too little time to address this. I'll lose money. Firstly, the BCG does muddy the water. Secondly, it depends on the age group. If they're already over 35 with a positive PPD, next is the chest x-ray. If they don't have any symptoms or problems, do you do a PPD? Even if it's positive, you expect the chest film to return negative. You're not going to do anything anyway, so why do you want a PPD in the first place? And if you expect something in the chest x-ray, why don't you do that in the first place? If they don't have pulmonary symptoms and they're fine, you're not going to preventively treat them anyway. Then why are you going through the procedure if you're not going to do anything different? I think it's wasting money, okay? He sort of talks himself out of it. The interviewer goes on to say, if you didn't have to do a 2-step process but a single blood test, what do you think of that? The answer, well, that's a great improvement, of course, but it still boils down to what is the significance? How does it affect your management of the 89-year-old lady who's asymptomatic with a negative chest x-ray? So, in conclusion, I guess I would say that while education and working with docs in the private and public sectors does significantly improve knowledge, it's much harder to change attitudes, and this doesn't surprise any of us, I don't think. And it turns out that context of practice is particularly important, at least in this study. For many of the TB control clinics that work with FQHCs, that's the low-hanging fruit. That group of people, those physicians, seem to be the most inclined, have more resources, and have a culture of prevention in their setting. The harder to reach physicians are those fee-for-service, sometimes foreign-born trained physicians that are in small or small group or solo practice out in the communities, and they are higher risk and harder to reach population. And I think the strategies for contacting them are slightly different than working with larger resources, the larger settings that have resources and have predisposition to treat. So in conclusion, there are many features of primary care that impact screening and management of LTBI beyond knowledge. Practice size, as I mentioned, and fee-for-service setting versus salaried setting. Private practice physicians seem less familiar with current guidelines on how to be fair. Because of the sample size, there may have been some collinearity between age and duration in practice and being in private practice. But that said, they still seem less familiar, more concerned about INH and BCG than the community clinic setting. So educational interventions can improve knowledge, but have little impact on these attitudes. And future interventions should consider different approaches to practice settings and address priority concerns beyond education. And I think what we mean by this is practical tools, and I think that the next speakers are going to look at some really practical tools beyond education, tracking systems, contact with the TB clinic, and those things that lower the threshold to doing the kind of testing and treatment for latent TB in the private sector that we're hoping for. So with that, I'm going to turn it over to Ken Purdy.